This demo is SpineJack. How many of you guys have tried SpineJack? Good, so about half the room, that's great. But the majority was in the front here. They've tried SpineJack. All right, Dr. Yoon, are we ready to go?
We're ready to go.
Fantastic.
All right. Thank you for having me. I'm Edward Yoon. I'm from Hospital for Special Surgery in New York. And today I'll be going over osteocooled tumor ablation system, as well as Kyphon Assist from Medtronic, as well as SpineJack titanium implants for Kyphoplasty. So first, before I demonstrate the procedure itself, I wanted to kind of turn your attention to the chicken breast as we are starting to ablate, if we can concentrate on that. So as you can see, this is a chicken breast, and there's an outline of the vertebral body, and kind of imagine that there's a tumor in the vertebral body that we're trying to ablate. It's a bipedicular access, and it's a bipolar burn, which creates a large lesion within the vertebral body so that we can kind of completely ablate the...
So Dr. Yoon, can
Yes.
I interrupt just for a second? There's a little bit of a glare on the front part of that vertebral body. I don't know if it's possible to, yeah, that's perfect right there, yes.
Sorry about that.
No worries, thank you.
Perfect. So as you see, there are two kind of radiofrequency probes that's inside the proposed vertebral body, and it's going to create a lesion. It's going to burn for about 15 minutes, and at the end of 15 minutes, you'll be able to see the lesion size, at least in a chicken breast model. It's an osteocool system, so a cold, normal saline is running through the whole time, just like Dr. Phillips showed earlier in the morning today. So the temperature of the lesion actually reaches 80 to 90 degrees, even though the temperature here states that it's 60 degrees. So you have cooled, normal saline running the whole time, so there's less charring at the needle tip and kind of lower or less impedance issues as you're ablating. And so now for the purposes of bipedicular access, I got access on the right side already using a traditional transpedicular access, and I'll kind of demonstrate how we go about it on the left side here. So before we do any procedures in the spine, you always want to square off the end plates at the level that you're working on and have the spinous process in the middle and getting a true AP image. So we're going to start about 1 centimeter up, 2 centimeters out. So just to save a little radiation, I'm going to hold my needle in place right there. So I'm on os. So we'll slowly start advancing the needle. So as you have mentioned already, the only cardinal rule and the potential danger of this procedure is essentially the needle going into the central canal. So just making sure not breaching the medial wall of the pedicle before you get in the posterior wall of the vertebral body. And I don't know if you realized, I turn my needle 180 degrees, so the bevel is facing towards me, which buys me additional 3 to 5 millimeters in terms of space. So I'm right at the medial wall of the pedicle, so we'll get a lateral here just to check our depth. And I know it's going to be fairly good because, Dr. Beal always says, look at the patient. Sometimes we get so enamored by the fluoroscopic images that we're getting that we don't pay attention to. So I moved the interstylet of the one that was already in. So we're already in the posterior wall of the vertebral body. So I'm going to turn the bevel medial again so I can fly in medially. It's going great. All right, perfect. So I'll put the needle back in. We'll come back AP just to check our final positions of the needle. So that's essentially the only kind of dangers of kyphoplasty, us violating the medial wall of the pedicle and getting into the vertebral body. And I don't know, in your experience, Dr. Beal, in terms of getting epidural leakage of cement, I feel like a lot of the the danger happens when we're breaching that wall, hence you get the epidural spread. Because most of the time, as you mentioned before, I feel like it goes into the basivertebral plexus, and it's well kind of insulated and protected by the ligaments that you mentioned in the posterior part of the vertebral body. Okay.
Whenever it does start to extravasate, especially in the basivertebral plexus, just pause.
I'll just take the balloons at
You
this
have
point.
time, let it harden. It will harden a lot faster
This
in the
bone is
body
super
than it does in the
soft.
back table.
We'll come back to lateral.
So once it's hardened, you can continue on. It plugs your abnormal egress routes.
And so thankfully, this cadaver, unlike the cadaver before, has osteoporosis, just like our patient, or most of our patients that we're treating. So we'll introduce the balloons. And sometimes when you advance the needle and you try to get the balloon in place, you'll have a lot of resistance. And if that's the case, then you can actually use a drill that's available. I'll kind of show that right here. So right here, this is a drill that could be used to kind of drill into hard bone if there's a sclerotic bony metastasis or something like that, to create a track for the balloon to actually go in. So, all right. All right, perfect. So I'll slowly start inflating the balloon. So depending on the type of fracture that you have, the Kyphon assist will kind of direct the balloon into the area that you want it to go to. So in this case, I'm kind of aiming the balloon towards the superior end plate. Obviously, this patient does not have any vertebral compression fractures, so it's going to fill very nicely. There's not going to be any issue inflating. So this will tolerate up to 700 psi. So we'll keep going. Perfect. Oh, can we make some cement? Yeah. And then it's been about 6 minutes, and you can already start seeing the ablation if you can get the skin, the chicken. Can you see that well, Dr. Beal?
You can see it very well.
Yeah, so you see this white portion of the chicken getting cooked very well. And obviously, we don't want the ablation going too posterior, but I feel like a lot of the times, if the posterior wall of the vertebral body is intact, it can really act as a good insulator. Whenever we're doing osteoid osteoma in the spine and other lesions as well, it's been proven that you don't really have to worry as long as the cortex is intact, and you don't need like a thermocouple or anything like that when the posterior cortex is there to protect it from heat.
Exactly.
You want to start access? SpineJack ones on.
No, we'll just do this first, and then we'll do because I don't want the needles running into. All right, so we'll deflate the balloons.
So as Dr. Yoon mentioned, those are express and expander. Those are the expanded balloons. They're low compliance, and they're rated to 700 psi, but they'll go far higher than that. We've tested them in excess of 1,000 psi.
All right. So I'm just going to prime the system, just making sure that the cement comes actually all the way out of the cannula before actually giving it. So right now, you could kind of see how runny it is, but that's okay. For the interest of time, we'll just start right away.
What type of cement is that? Kyphex, or is that X-Speed? Or is that Kyphon?
X-Speed.
Okay.
So we'll always, most of the time, fill under lateral. So we'll take an image before, and you see that air in the spot where we already put in the balloons. So we'll kind of fill that first. So I like to use the balloon not even for the purposes of reducing height, but at the same time for some of these subacute fractures. So I'm going to just slow down a little bit. So this is a hydraulic system, and there's a stop, essentially, button that will kind of stop the cement from coming out. So I'm gonna go to the other side since it's fairly runny. So the cement is very runny, which is why we're seeing it posteriorly there, but just like Dr. Beal mentioned, no, it's,
You're out of
oh, are we? Okay, perfect. Let's change that.
So this is a hydraulic delivery with the water providing driving force for the Expeed cement, which is a quick-to-dough cement
Right.
with about 8 to 10 minutes of working time. And this is a hydraulic driving device. And this is the plunger, this is the cement.
Right. So I'll slowly start giving more cement.
So he's triggering this, and it's like a delivery gun, and it has a back release valve for an immediate stop.
So, I mean, after I remove the needles, you'll probably see, Dr. Beal, but you kind of see that what we're talking about in terms of the basivertebral plexus. And, you know, if it was anyone else, they'll be kind of afraid, oh my God, it's going posterior, but it's unless you're just continuously giving it, the patients are gonna do just fine. All right, let's take an AP right here. Perfect. Yeah, come more towards me. So patient has an IVC filter, and that's perfect, right? Pedicle to pedicle. I mean, if I wanted to be more like Dr. Beal, I'll be giving even more cement, but just for the interest of time, I'll move on to the next case, where I'll be showcasing SpineJack.
Nice heart-shaped cement distribution.
Yes, my affinity for kyphoplasty. Can we come to the level below? So this is Stryker SpineJack. It's more of a parallel approach, so kind of like more like a BVN ablation. So you'll start right over kind of the outer edge of the transverse process there. And the patient here is fairly thin, so I'm already on os. Okay, there we go. Give a few taps here, get access. So I'll start really medializing it because I started fairly lateral. So this is kind of a mixed, I guess, parapedicular access here. So, all right, good. I'll do the other side just for the interest of time. And just as Dr. Beal mentioned, you know, I love that with these bevel tips I have steerability, and that I can buy more, sorry, right here, that I could buy more time. So just like a quincular spinal needle, it will slowly kind of move away this way if I'm advancing the needle, versus a diamond tip, sorry, which is next to it. It's easier in terms of getting the initial purchase of the bone, but a lot of our patients are osteoporotic anyway, so I don't really have any issues with getting initial purchase, I feel like. So again. So if the patient is very osteoporotic, I can almost advance the needle. Sorry, it's falling away. There we go. Good. right? And we're lucky that the patient has a pretty robust pedicle. So here, I'll again turn the bevel 180 degrees the other way, buy myself a little more room here. All right, lateral. So perfect. So I'm in the posterior wall of the vertebral body with both needles, so I could really medialize it. So we'll go all the way anterior. And the other one, I'll actually just take the K-wire. And for patients with severe osteoporosis, you just have to watch out. Even the K-wire, even though it has a blunt end, if you want to show that, it will fly right past the anterior cortex. It has a blunt end, but when the patients are severely osteoporotic, it will go right through the anterior wall of the vertebral body, even when you're drilling. So you just have to be mindful and be careful that you're not going too anterior, especially if you are on the left side. I'll take the other K-wire, please.
You can see by his needles that this is going to be a good angle. The needle access for a transpedicular approach is typically 30 degrees from plumb line, and this will be closer to about 45 degrees based on his ability or the need to put these medialized as much as possible.
And another thing is when you're removing these introductory cannulas, just make sure the K-wire doesn't pull out with it. Just as it can go anteriorly through the anterior wall of the cortex, you can also lose access at the same time. And I've definitely done that with Dr. Beal as a fellow, and he was not happy. So don't do that either. Just like when you're doing a stim, make sure you give a little counter traction or counter force as you're taking the cannula out. Make sure it's not pulling out with it. So before I put in the drills or the reamer, I'll check a final AP image just to make sure that I like the positions. Love that. All right, come back to the lateral, please. So we'll make a decent-sized nick at the skin where the K-wires are at, just so that the reamer can go in. You also don't want to ream the skin or the soft tissues, right? So you want enough. So the way I like to do it is I like to spread the skin open as I'm initially introducing it, because you don't want to ream someone's skin off superficially. So we'll just go in like that very easily. Then I'll take oh no, never mind. So we'll start drilling here. And on osteoporotic patients, just like I said, the K-wire can just fly anteriorly as you're advancing this drill. So just making sure that it's not pushing the K-wire at the same time with it. So we'll go all the way. Can actually remove it. And if you really want to kind of adjust your needle trajectory, you can also take the K-wire out a little bit earlier and medialize it or lateralize it as you need to. So we'll put in a clear marker here so that we can still see the drill as we're accessing the other side. So again, kind of pulling apart the skin as you're advancing the drill into the soft tissues here. Good. Perfect. All right. So today we're using 5.0 SpineJack. There's 3 systems or 3 different sizes. They're color-coded. This is 5.0. I think we use this the most. And then it will deploy in a craniocaudal dimension along parallel to the handle. So whenever you're advancing the SpineJacks in and before deploying, you just want to make sure, especially on scoliotic patients, that your handle here is going to be parallel to the end plate in a way that you're trying to reduce it in. So this patient doesn't really have scoliosis, so it's just going to be straight on, up, down. And if you have a friendly fellow that can help out, you can actually have them stand on the other side and have the handles flip the other way. So the other operator will be here deploying the SpineJack on this side as I'm doing it on this side. So with the handle, as you're holding it parallel to the end plate, you're going to slowly deploy it. A few turns here. I think there's 13 turns max that you can get to here. Okay. So I'll give it. And especially if you're doing tumor or severely osteoporotic patients, you don't want to, once you start deploying it, you don't want to, wiggle the handle too much because you don't want this swiveling around in there in the vertebral body. So that looks great. So again, this axis is more like basivertebral nerve ablation where we're coming in flatter rather than the 10 to 2 o'clock position. We're coming in at a 3 or a 9 o'clock position, and we'll go all the way. And one of the benefits is that when you're using this system, a lot of times on the lateral, you'll kind of get nervous because it seems like the skis are violating the end plate, but it's actually not. Dr. Beal and I, whenever we did these, we would always get CAT scans after. And even though it looked scary on the lateral, it just looked like that because, the vertebral body is concave with a concave portion being in the middle. So it looks like it's going through the end plate, but it never really is. So you could be comfortable when you're really reducing this. So you'll feel a hard stop once you can't go anymore, and then you'll start counter-turning the other way on this blue spot, and that's 10 turns, and it will come out. Same with this one.
So he's loosening that very well. If you find that you can't loosen it, you can take a couple of counterclockwise turns on the butterfly handle to take the pressure off.
All right. So we'll slowly.
So it's high viscosity cement.
Yep, from HV.
Vertiplex HV, and you can kind of see that that's pushing the bone filler back. It's very viscous.
Just for the interest of time, I'm just being fairly aggressive with how fast I'm giving the cement, and obviously this patient does not have any vertebral compression fractures, so the distribution is gonna look amazing. As usual, let's take a look AP. It might have almost crossed to the other side, we'll see. If not, I'll put in the cement on the other side. All right, never mind, I'll go to the other side. Any comments or questions in the interim?
Questions, comments? So Dr. Yoon, when would you favor a SpineJack over balloon kyphoplasty?
So anytime there is an air cleft or a non-union, they used to call it Kummel's disease or avascular necrosis, but essentially it's a hypertrophic non-union, as you said. So you know that fracture, regardless of the age, is going to be reducible, right? So that's where I favor SpineJack, as well as if it's in a thoracolumbar junction where you know that, really getting that height restoration is going to be really important. And I was actually discussing with the Medtronic and the Stryker representatives here in terms of the chronicity of the fracture as well. Because if you're treating a patient that's 4 to 6 weeks out and they're not, crazy osteoporotic, sometimes when you're actually accessing with a cannula, you kind of get the feeling that's, portion of the fracture has already started healing with sclerosis, and that's where you kind of know that you're not going to really truly get the reduction that you're desiring with the SpineJack. So then that's when I would just use balloon kyphoplasty. So how to kind of disengage the system, there's a hole here that you can put the K-wire through, and it's a counterclockwise turn a few times, and then you could just twist it out. And that is the SpineJack.
Beautiful.
Any other questions, comments? All right.
The rod and screw system?
Yes. Yeah, the anterior column can, you can replace the anterior column access with the spine jack posteriorly. Absolutely. All right, Dr. Yoon, well done.
Thank you.